Our guest this afternoon is Dr. James P. Youngblood, who was president of ACOG not these many years ago. 98 and 99, was it, Jim?
Yes, it was,
yeah.
Yes.
And, of course, got there as the result of having had a long and distinguished career and certainly getting along with a lot of people, I think.
Yes.
Did very well at it. Let us begin someplace a bit close to the end. And what was the succession that led to your election as president of ACOG?
Well, after finishing medical school in 1957, this year is my 50th graduation year, went on to residency at the University of Michigan, where I had gone to medical school. Finished in '62, spent 2 years in the Air Force, whereupon I came to Kansas City, and I've never left Kansas City, Missouri. Practiced there for 20 years, during which time I started my career with ACOG by first being a fellow after passing my boards, and then became a section officer in 1976, where I met my best friend, Pete Hollis, the very first time on an elevator. And
well, that was a good start.
That was. And we were both starting at the same time. At any rate, I became a section vice chair and then section chair of the Missouri section. And then with a layoff of a year became secretary of the district. That at that time happened to be a 4-year term just because of the way things fell. And following that, I was vice chairman of the district and then district chair of District 7. Meanwhile, at the urging of yours truly, Dr. Warren Pearse, I became involved with CREOG, which is Council on Resident Education and OBGYN, and was with that organization 9 years, the last 3 of which I was chairman, which coincided with the same term I had as district chair of District 7. And that ended in about 96. There was a year hiatus in which I ran for president of the college and failed, and then 97 I was nominated to the college presidency, and after that was president in 98 and 99, and then past president 99, 2000, and that was my career in ACOG. And I still am active with the district and with the national, and have been on various committees in the national since then.
Are you still practicing obstetrics and gynecology?
I still am. I was chairman of, I left private practice in 1984 at the request of Harry Jonas to take over the chair of OBGYN at UMKC School of Medicine, which was quite a switch. And in essence, I had 2 careers. And as chair, I was chair for 23 years, stepping down a year ago right now. And
that must be some kind of a record, isn't it?
well, for me it was, but at least it was a very, very enjoyable time, very, I thought, productive. I enjoyed both my career in private practice and also my career in academic medicine. And after I stepped down the past year, I'm still have a small private practice, and I'm working 3 days a week in the medical school and in the hospital, and I run grand rounds and do the things the chairman asks me to do. And the best of all is that I don't have to make any decisions. Yes. So anyway, it's been a very fun ride, and I've had a great deal of fun doing it.
Of course, those of us who spent a lot of time in the Midwest remember you well from the Midwestern days.
Right.
Was there a particular area OBGYN that was of interest to you or that you focused on?
Well, I was a generalist, which means that I got to move around a lot as far as my interests were concerned. In private practice, it's always a learning time, and of course, after 20 years in private practice, I didn't do anything the same as I was trained, and we, you know, colposcopy came along, and we learned that, and then ultrasound came along, and I became very interested in that, and was very instrumental in our community in getting ultrasound, office ultrasound, obstetric ultrasound started in the community, and that became a major interest, and I actually even did a couple of studies while I was in practice, and after I came to UMKC as chair, I insisted that that obstetric ultrasound stay in the Department of OB-GYN, where it still is.
Yes.
And every so often there would be a new chair of radiology, and he would make a run at it, and we would stave that off, and we continued to have. At any rate, after I was chairman for a while, Dev Malik joined us, who is an ultrasound and Doppler expert, and he took that over pretty much, and I turned my interest to pelvic floor disease and support, and became very, very interested in incontinence, and helped Cullen Richardson develop the perivaginal defect repair and so on. So that was the last part of my career, is that I became very interested in that.
Did you continue to practice obstetrics through those years?
I always have, but
Always
not with private patients, just with the residents and so on, as an attending. But I never, I cut off my private obstetrics practice when I came on as chair.
Are you still teaching?
I still am teaching, and as I say, I'm in charge of grand rounds. I'm on the institutional review board and the what do we call it? The self insurance trust at Truman Medical Center, and I'm one of two physicians on the management committee of that. So that has been very interesting also.
Were you ever tempted to practice someplace else?
Yes, as a matter of fact, very early in my career as chair at UMKC and Truman Medical Center, Henry Ford Hospital asked me to chair the department, and I went back and forth several times because I'm from Detroit, and as I know, Dr. Pearse is from Detroit. Yes. And so I went back and forth several times, and they almost had me. The thing that we decided with my wife, that if we got the house that we were looking at, we would go. And we didn't get the house, so we stayed, and that was that. So, and I'm very, very glad it turned out for the best.
It's kind of close to the heart because my wife is a graduate of the Ford School of Nursing.
Is that
Yes,
right? I
indeed.
didn't realize that.
Being also a Detroit boy, as you said, where was this house that you were looking at?
This
will not go down in history. But
it was on Windmill Point in Grosse Pointe.
Yeah,
it was right on the water.
Right on the water.
It was a spectacular house, and I could afford it too. That was the other thing. But it wasn't very large. It was just a very nice place with a good view on Lake St. Clair.
You could watch speedboat races out there.
Speedboat races, sailing, all the water sports were right there, which we don't have in Kansas and Missouri, at least not close by.
Were there some particular areas in obstetrics or gynecology that you especially devoted attention to?
Well, especially in the last years after ultrasound, it was pelvic floor relaxation and the things that were related to that. I enjoyed working with that. We did a fair amount of research on it. There was a small cadre of people in the country who were interested in it, and we got to be good friends. The anatomist in that group is still very, very active, Dr. John Delancey at University of Michigan.
Know him well, yes.
Yes, and he is just a spectacular researcher in the area, and so I've enjoyed all that very much.
Where has retirement led you?
Well,
geographically different, or
no, except I have a place. We did buy a condominium in Naples, Florida, and we've been renting it out for most of the season, the winter season, for the last several years, looking for the day when I would step down and work less. And so this winter, we did spend 2 months in Florida, and that was very lovely.
I would guess, with the attention you've paid to graduate medical education and the facets of it, you might have some thoughts about how residents are trained these days. Is it being done right?
Well, it's being done the same way. That was one of the issues that I was most involved with as president of the college, and was especially resident education. And the fact that because of so much that was trying to be taught in a short period of time, in 4 years, the breadth and depth of the specialty included so much: obstetrics, gynecology, oncology, maternal fetal medicine, and all of that, that there was short shrift paid to surgery, which really is part of our specialty. And so I battled hard with the RRC and the board, and trying to do something that would enhance it for those who wanted it, and talked about a 5-year residency, or a specialty of pelvic surgery that could be added on to a residency, and so on. And we did make some progress. We were able to, and the board was with me with this, and was trying to convince the RRC that we could do something different that would help. And in fact, there is in place a option, whereas if the residency director, program director, approved, a resident could opt out of his 4th year or her 4th year and go on to a subspecialty, and that would shorten the entire training period by a year. And as Dr. Norman Gant chides me all the time, he says,
as he would,
it's there, but very few take advantage of it. You'd have to have a large residency program to make that work. Yeah. So, but he said, I talked to him about it yesterday, as a matter of fact, and he said that about 30 or 40 in the last 2 or 3 years have taken advantage of it. So that we did make some progress, but that was.
Well, I mean, your decisions seem to me like wisdom. You want to educate people for the place they practice, in the way they practice.
That's correct. And in fact, the conference, the National Advisory Council conference yesterday, was on this very subject of resident education, and as you might expect, Doug Lobby has driven that. That has been his issue this year as well. So I thought that was a very good conference yesterday, and much of this was brought up in the fact that now the depth and breadth of the specialty is so great that we have to start narrowing it down in some way, and we don't want it to fragment, but neither do we want it to, push everybody out of the same cookie cutter, as Drogemuller says.
Expression goes.
Yeah, right.
Do you think that that approach is going to take on, that is, most people in the same pattern, but some sub-specializing in the course of the residency?
I think that what they told us yesterday was that each year in the last 5 years, more and more people have gone into subspecialties coming out of residency, to the point that they're all oversubscribed now. All the subspecialties are, all 4 of them if you count urogynecology, and which we might as well do because they're all doing that.
Was there a thought, what reasons were pushing that trend?
I think these weren't brought up, but it's my observation.
Okay, we'll take that.
All right. One of the major things, I think, is the shift in gender in the specialty.
Okay.
And many men have seen the handwriting on the wall and want to go into a subspecialty because they can't get any traction in the generalist arena, because the women are kind of taking that over, and it's obvious, we see it. So, and there's nothing wrong with that. I think that's fine. Also, many women especially are interested in, of all things, urogynecology and maternal fetal medicine, especially. Those two especially. Not that they're not interested in the others, but I think they're, from my observation, are gravitating towards urogynecology. And I think they identify with urogynecology especially, and as well as maternal fetal medicine. So.
As we come along into this year of 2007, what are the numbers of men and women in obstetrics and gynecology?
Right now?
Right now.
They're about, I mean, practicing you're talking about?
Yes.
Right.
Real doctors.
Right. They're practicing physicians, that was pointed out yesterday, were about equal now, 50-50.
Are they?
Yeah. And of course, residency now is about, depending on where you are, but between 75 and 80% women.
This I've heard. Oh, yeah. I wondered.
For the last 5 years, our residency we have 32 residents, and 28 of them have been women. We almost always get 2 men a year and 6 women. So, and there's no other specialty like that is attracting women like that. So,
Do you think both men and women in obstetrics and gynecology are happy with that situation?
No, the women aren't happy with it. They are. It's really interesting to see our residents during the recruitment phase when we're interviewing applicants and so on. They're actively recruiting the guys. They very much are, and they see this disparity and they don't like it, and they would like to have it more evenly divided. For a whole bunch of reasons, and I'm not going to go into them.
Do you think it'll change?
No.
No.
I think
probably
it
not.
Probably stay pretty close to where it is. And I think the men will continue to veer off into the subspecialty areas. The 2 men that are finishing, for example, this year, one is going into a subspecialty and the other is going into private practice. And all the rest of the 6 women that are finishing with them are all going into private practice. So, and that's interesting. Some years it's the opposite, but almost always at least one of the men goes into a subspecialty.
Do you have any feelings about the quality of graduate medical education in OBGYN, which of course might partly be influenced by the gender question too? I think
the quality of the education is very good, and I think the quality of the applicants, given the fact that I think that in general the quality of applicants to medical school is not what it was 10 or 15 years ago.
That's probably right.
But I would think that the quality of the folks coming into OB-GYN is higher than the average. That's my observation. It's narrow, I know, but looking at the 32 people we see, that's what my observation is.
Granting that you're probably right, is there a reason for that, do you think? It's an interesting observation.
Well, there was a lull in medical school applicants for some time, as I know you're aware because you've done all the studies on this, but because of various factors, malpractice and reimbursement issues because of managed care and the government regulation. And all of those things in medicine in general have kind of turned off the spigot for a while. And the most qualified people were going into areas of engineering and scientific endeavors in other areas. And again, an observation that I think is pretty well corroborated.
You think medical students today see OBGYN as a good and useful specialty?
They didn't for a while. During the past 4 or 5 years, let's say the last 7 or 8 years, the numbers were way down compared to what they were in the 90s. And in the last 2 or 3 years, we've noticed that, and we have made a great effort in the medical schools through the efforts of our past president, John Gibbons, and his efforts with getting medical students interested in OB-GYN. And I think almost all programs now have interest groups in OB-GYN in the medical schools. We have a very active one, and I know most schools in the Midwest for sure are doing that, and they're actually increasing the numbers by a lot. I mean, this year compared to last year is way up, and last year compared to the year before was way up.
Do you have any feel for what's going on in clinical research at the residency departmental level? What interests young physicians and from a clinical standpoint?
Given the fact that where I am is very much concentrated on clinical obstetrics and gynecology, I would say as you know, we all have a requirement that they do research, and so I would say 95% of them do minimum what we say they have to do, and they do that. But there's always one or two out of the group that go the extra mile. They prepare almost a paper a year. They do all that. I think you may know of one of our graduates from 20 years ago, Kathy Spong.
I certainly do.
And she was just like that as a medical student, and she was doing research all over the place in OB-GYN. So that was a medical student. She didn't train with us, but she went to UCLA and then to the NIH. So.
Well, you've certainly had a lot of interest in clinical aspects of obstetrics and gynecology, and I know have contributed to it. Do you see any exciting things in the modes of delivery, approaches to pregnancy care?
Well, the buzzword now, Warren, is simulation.
Okay.
and so the dean of the medical school has asked me to develop a program in simulation, not only in OB-GYN, but in the other specialties as well. So she even gave us a 4,000 square foot space finished in order to do this. So just got it. In fact, we haven't moved into it yet. But
now, what do you simulate?
Well, in OB-GYN, we simulate various and sundry things, going from the very technical, like laparoscopy and things of that nature. And we have, we started with the rudimentary pelvic boxes with, they blindly stick scopes in and so on. And now it's much more sophisticated, and we've actually gotten some of the surgical instrument companies to donate robotic things for us to use. So that would be the technical things, and then right down to the very simple knot tying and things of that nature, repetitious type efforts that young residents can do. And then in the areas of obstetrics, simulating events, and by simulating I mean actually having actors act it out and so on. shoulder dystocia, breech delivery, forceps delivery, eclampsia, which you know is usually a fire drill, and hemorrhage, things of those natures, and in other words, obstetric emergencies, when you have to work as a team, think as a team, do all the right steps and so on. And it's easier to do that on simulated patients than it is on real live activity.
You know, I think with your interest, you would have a feel if there are areas in clinical medicine which we're not approaching well enough. Do we need more simulation? Do we have to depend on what problems appear in your doorstep?
I think we need more simulation. I honestly do, for several reasons. The chief of which is the patient safety things that have been thrust on us by the Institute of Medicine and that kind of organization, and rightly so. We have to be aware of patient safety, and the best way to do that, I think Ben Sachs has it right at, I'm always going to misspeak about the hospital he's at in Boston, part of the Harvard chain, but I think it's Beth Israel. But he and his group have done a very good service to the specialty and showing us how to do the teamwork to bring safety into the labor and delivery area especially, and things of that nature. I mean, you just can't have patients being passed off at the change of shift and not everybody know exactly what's going on and things of that nature. You can't go into the operating room not knowing everything about the patient, and that goes from the intern to the attending. You cannot have a resident go in there who's never seen the patient and do the operation. That's not the way we can do things now. So I do think that patient safety is driving this. The 80-hour work week is driving this. There isn't enough time in the day to teach all of these things, and so we have to do it in a simulated manner.
It sounds to me as if you've approached this very carefully and looking at both clinical and scientific approaches to education.
We keep trying, and it's everything is a work in progress. So.
Let me perhaps wind up a really interesting conversation, which is what I expected.
Well, thank you.
What do you see in terms of obstetrics and gynecology as a specialty over the next few years?
I wish I had a crystal ball, but I think that as a specialty, that it will become stronger. It will change. It will have to change because of the changes going on in medicine and what are driving government and regulatory bodies and what patients want and what we as physicians want. We have to think of what we want to do also, and we have to do it with safety in mind, and we have to bring all of our forces together to make the OB-GYN specialty work. The one thing I see that could happen that you just hear a few rumblings about is a split of the specialty back to what it was early in the 1900s, when it was obstetrics and gynecology, and gynecology was practiced by the surgeons. Yeah.
Yes.
And the gynecology was practiced by the surgeons, general surgeons generally, and they were two different specialties. I would hope that doesn't happen, but certainly we have to, in my opinion, keep it together because we're talking about one woman, not a fragmented woman. So,
I think your opinions are well thought through, which does not surprise me a bit.
well, thank you.
Appreciate your coming by to chat with us, and you're going to carry, this will carry a viewpoint
Well, thank
on
you.
into the future, which I think is going to benefit us.
Thank you, Warren, and thank you for having me. I appreciate it.